although we are late for the lunch, I will talk a little bit about diet in this presentation. The outline will be a brief background and then about diet and psychotherapy and much less on alternative therapy in irritable bowel syndrome, the most important functional disorder. And I'm going to skip to repeat the definition of IBS that all of my colleagues knows to shed a light on the therapeutic possibilities in IBS. And these are not only pharmacological, but as well they are dietary and psychotherapeutical interventions just close to behavioral interventions and the alternative options. In the Rome criteria works, you see the proposals how to treat IBS and the recommendations that is to individualize therapy according to the subtypes of IBS. And you see that some of the forms require non-pharmacological drugs, and we will continue focusing on this. At the end of the last year, an European group led by Paul Moaedi published a similar recommendation where non-pharmacological interventions should be included in the management of IBS patients. And thinking non-pharmacological, we say diet, of course, behavior, changing lifestyle, and of course, physical activity. And then it's very important the relationship and the counseling of the patients. That will be for next year maybe. Now it's speaking on diet. It's so hot now to discuss FODMAP, the fermentable oligosaccharides and the alcohols. And here is a list of foods that are recommended on FODMAP diet, less FODMAP diet. And here is one of the Rome slides showing that low FODMAP diet is reducing symptoms in IBS. And this can follow for several times in IBS according to healthy controls, but not all data are as enthusiastic as this one. Anyway, Satish Rao showed not a long time ago that supplementing with fibers is useful in IBS constipation that we knew for many years, and the FODMAP restricted diet is also effective in the short-term, not long-term therapy of IBS. So that's what we have to retain. And together with my colleagues from the Department of Nutrition of the Faculty of Pharmacy in Cluj, we were proud to produce this pyramid on IBS, starting with the idea that we should not tell to the patients not just not to eat, just to avoid, but also what they should eat. And I'm not going to read all this now, that you can find it open access, but you may see that there are recommendations in a dietary intervention of IBS patients that follow the general advice for healthy living, but also some specific recommendation according to the use of poor FODMAP content foods or vegetables, and to avoid at the end the less healthy food. So for the moment, this is, I think, a good advice that we could recommend to our patients with IBS. Not only the quality of the food is important, but how we eat. And it seems that irregular meals are unhealthy not only for dyspepsia, but also for irritable bowel syndrome. And anyway, binge eaters may be at risk to develop IBS symptoms. But binge eaters have also psychological problems, and the psychological patients also report IBS symptoms more frequently. Few people speak about alcohol and coffee and IBS. And Professor Zeitz has an excellent book on alcohol and GI pathology recently. But I would stress that there are not impressive evidence. It's not much evidence about the impact of alcohol on IBS symptoms, except women drinking too much. But this could be not only the effect on the gut, could be the effect of the brain as well. So no specific recommendation on alcohol consumption, beside moderation, of course, in IBS patients. What about coffee? Here also not specific evidence, but it seems that coffee drinkers are not more numerous in IBS than in control. So again, despite individual reactions like diarrhea, in few persons who refrain from drinking coffee spontaneously, is no reason to recommend coffee abstention. About spicy food, we have two possibilities. One is the acute ingestion of spicy food that we can experience when going to the Indian or the Vietnamese restaurant, and here we know from own experience that they produce gastrointestinal symptoms, and in IBS patients would be more frequent. On the other hand, some Indian papers show that long-time use of spicy foods like capsaicin is healthy. So again, we recommend to the patients to adapt the ingestion of spicy foods according to own tolerance. Then another hot topic is gluten. And it's not only celiac disease, but it's also non-celiac gluten sensitivity. The problem is that sometimes it's very difficult to differentiate between celiac disease and IBS-D. And sometimes we can accept that patients with IBS-D may also have celiac disease, like also patients with cancer may have celiac disease. Not only gluten is important in developing IBS-like symptoms or IBS symptoms, but also other contents of wheat or other cereals like fructose or inhibitors of amylase trypsin. So not only gluten may be responsible, but it's again is no absolute recommendation to avoid gluten. People with IBS should eat normally gluten. And the motto is, from Medscape, matching the right diet to the right patient. We should not be dogmatic. But in the bowel are also microbes. As has been shown, the microbes may have variations in IBS, like Johannes Professor Pohr showed before. And diet is able to influence microbiota in humans, but as well as animal. I will not read this table now, but we accept this. And therefore, people try to replace changes in microbiota with probiotics. And in this list of indications of probiotics in gastrointestinal disorders, some refer to IBS, and there are indeed several probiotics which can be added to the diet of our patients, for instance, as yogurts or as probiotic drugs. Behavioral changes, I will not follow too much. Very few cases with transit changes require anorectal biofeedback, but anyway, we have to advise patients to have a healthy lifestyle, to drink liquids, to practice sports, and so on. And now we have psychotherapy. Here is the dream of our important sculptor Constantin Brâncuș or Brancusi. Which patients should receive psychological treatment? And the group from Chapel Hill say who? Those who have quite severe, over the average symptoms, longer than 3 to 6 months, or who failed to respond well to the normal psychotherapy. What kind of psychotherapy? Based on what I favor is CBT, but also we can use other forms according to the experience of the therapist we work with. Alex Ford has shown that the results of psychotherapy is quite fine. The number needed to treat in CBT is 3, psychodynamic is 3.5, stress management and relaxation 3, hypnotherapy 2. That's quite encouraging data. And here is a meta-analysis of Paul Enck, again a German. He put together some years ago, was on the first meta-analysis, different studies. Most was CBT, 1 or 2 were psychodynamic psychotherapy, and at the end you see that psychotherapy is really useful. And then my colleague, Teodora Blaga Surdea, working with us, had look for some factors in the systematic review and emphasizing catastrophizing and somatization. Both Romanians have a very high score of catastrophizing, which we showed. Somatization. And CBT, we showed, is focused on replacing maladaptive coping strategies. These are lacking in IBS patients. It's effective in reducing IBS symptoms. And another more recent meta-analysis showed that CBT is indeed useful, and it's also focused against health-related anxiety, in this case gastrointestinal symptoms. Gabriele Moser had done a nice study in Vienna some years ago, demonstrating again the efficiency of hypnotherapy in this case. And this is a follow-up study of Gabriele Moser. She sustained, there was a more recent paper, after 4 years, the results of hypnotherapy in IBS patients in Vienna is very well preserved, so very good results. And this Shepard showed also in a meta-analysis a few years ago the sustainability and the efficiency of hypnotherapy in IBS. So besides CBT, we should use as well hypnotherapy or relaxation therapy. And here look an audit of 1,000 adults going to the conclusion that results provide further evidence that gut-focused hypnotherapy is effective intervention for refractory IBS. The alternative therapy is for those people who believe in it. If we go in Romania, in rural areas, you may see still such traditional herbs sellers like here, but cave, take care. Many alternative therapies overlap with charlatanery, so we have to take care. In conclusion, IBS is a functional disorder, you know, resistant to normal therapy. Therefore, non-pharmacological therapy is required and has to be included in the management, and think to diet and psychotherapy always. So what is established? The individualization of the diet, using low-fat milk and some probiotics, CBT and hypnotherapy. What disappointed? Some probiotics and the alternative therapy. What are the hopes? Functional foods, that it's a new focus, and extension of the use of psychotherapy. And thank you for your attention.